I am Chadi, second-year interventional fellow at MedStar Washington Hospital Center. I was asked to present a challenging Sapien case. So we started with Sapien, but it ended with something else. I have nothing to disclose, but for people on social media, I highly advise people put some disclosure on their biography. By disclosing their content is not a medical advice. And I see a lot of people, including Dr. Greenbaum, he just stepped out recently. Dr. O'Neill joined the Twitter, so I think this is coming up along. 71-year-old man with a history of severe AS presented with progressive shortness of breath. He has been active, golfing and swimming several laps every day. However, lately his shortness of breath has been getting worse, and his past medical history is significant for hypertension, AAA, 4 centimeters, stable for several years, recent PE, and severe AS. His medications: metoprolol, rivaroxaban, lisinopril, and atorvastatin. This is the echocardiogram showing tri-leaflet valve with a velocity 5.9 and mean gradient of 99 and aortic area of 0.6. His ejection fraction was normal at 65%. Sinus rhythm in the EKG, no blocks, no AV or bundle branch block. So the patient was referred for SAVR because he really doesn't have too much comorbidities. Patient was interested in TAVR. He's not frail on the frailty score. On the 4 and the 5 measures that we do on every patient, and his STS score was 1.1%. So we have a low-risk TAVR trial where we don't randomize patient to surgical arm. We have one single arm. Everybody go to TAVR, and they get a commercial valve depending on the anatomy of the patient. So he signed up for the low-risk TAVR study, and coronary assessment showed some diffuse disease, 20% mid-LAD and 20 in the right, but otherwise non-obstructive. This is the CT angiogram. The annulus was 482. The area was, the parameter is 77. Severely calcified leaflet, as you see in the bottom panel of the pictures. I would like you to pay attention to the coronary heights. Both were 13 millimeter, both sides, as well as the sinus diameters and sinus heights, all within range. There is no extension to the LVOT. That's one of the things we also look for to determine the type of the valve we're going to be using. Based on the valve sizing charts for the parameter for the area that he's qualified for 26 millimeter S3 with 8% oversizing. And for the heart valve meeting every week, we just put every valve possible on the chart just in case we need to do some other device. So for the parameter, he qualified for 29 millimeter core valve Evolut R. At that time of the procedure done, the Evolut Pro was not approved yet in the US. So the iliac CT scan showing sacral aneurysm, 4 centimeter, as I mentioned earlier, it has been stable. There is no change for several years. However, the peripheral axis was kind of more challenging. On the right side, it has been as small as was 4.7 in the common iliac and 5.2 on the external iliac. And as you know, 26 millimeter valve S3 need at least 5.5. However, we thought probably this is going to be feasible with since there is no circumferential calcification on the left side. Despite multiple attempts, first of all, we did the root shot, as you see there, severely calcified leaflet, limited active. We did the BAV based on the CT scan and the calcification that we have seen. You see there's some calcification nodule just kind of pushed from the left leaflet upwards. And in preparation to put the Sapien S3 valve, the delivery system couldn't go, regardless how much we pushed from the left side. Therefore, we changed the valve from Evolut to Evolut 29. It was successful, going smooth from the right side since a smaller sheath, and the deployment was successful. However, there was moderate to severe PVL, as you see on the far right panel. Therefore, a BAV was post-dilatation with 26 millimeter balloon was done. I would like you to pay attention here around like 3 o'clock. I don't have the mouse. Yeah, here, see how the skirt here kind of getting pushed to the left side. A few seconds later, patient became hypotensive, cardiac VFib arrest. Our differentiation at that point, either it's going to be tamponade or coronary obstruction or annular rupture. Quickly through our troubleshoot algorithm, we did an aortogram. There was no annular leak, but we couldn't see perfusion to the left main. And echo showed no tamponade, but there was an anterior wall is down, suggesting left main occlusion. ABU guiding catheter was kind of advanced with some challenges. We were able to kind of get some perfusion. Meanwhile, other interventionists was getting access with balloon pump and ECMO. Surgical team were in the room, and they called for emergent CABG. This is just a post-dilatation image just showing how the lower third of the valve kind of getting pushed and the calcification kind of occluding. I think most likely the leaflet here kind of nodule kind of pushed to the left, occluding the left main. Patient was transferred urgently to the OR, successful Lima to LAD and venous graft to OM1. ECMO decannulated same night. Patient recovered, discharged 7 days later. So the highlights of the case is it's important to know when to stop. This is why we didn't push the Sapien valve. We changed to Evolute, and that was how we managed the challenge of S3. Hemodynamic support, I mean, I know we are going more and more toward minimalistic approach with less sedation, no swan gas, but however, there's some selection for patient. In this case, there was no predictor for hemodynamics indication. A troubleshooting algorithm by looking through the echo, having echo in the room, and also doing aortogram just to make sure go through the ABCs of complication for annular rupture. And also we have to consider special consideration for the population we're going to be treating going forward for low TAVR patients. I mean, this valve has been used for several years. I mean, for patients who are severely calcified valve with chances of having coronary disease. But now, as we're enrolling more young population, then the chances of needing further coronary angiogram and PCI in the future is higher. So the design of the valve probably should be considered, and valve selection should be also considered. And as there's some recent publication from the German literature suggesting that no need for surgical backup. However, I think this is clearly illustrate that surgical backup really needed in this population. Thank you. Ready for questions?
We're going to take just one question because we're behind. Go ahead, Mike. Let it rip.
Great presentation. Fortunately, it's not the Evolute trial. I have to take you outside and have a chat with you. As a young guy, I'm just going to tell you, you just presented a patient from a trial that's actively enrolling, and you gave us outcomes. Hopefully, nobody from the FDA is in this room. I suggest you don't repeat presenting this. You really should not give outcomes.
Which trial is this? This is your. This is the Washington Hospital Center registry, is it not?
Registry, yeah.
I still wouldn't do it. It's an actively enrolling trial.
But just to point out which trial it is.